It's all you now.
All right, thank you so much. Okay, so I'm Luis Medina-Garcia. Nice to be here with you again. We're going to talk about the tridemic, tidal wave of respiratory illnesses. Again, in this, I tried to curate the literature and news reports and what we know about what's going on and try to present it in a way that's friendly for everybody to hear. So this is probably not what you would hear at the IDSA meetings, but I hope that it's useful for our audience today. Next slide, please. So our learning objectives. What in the world is a tridemic? How did it come to be? What is the role of masking, of the lack of social distancing, of vaccination, and the very talked about theory of immunity debt in all of this? We'll briefly talk about the picture in the United States, a little bit about what's happening in the state of Nevada, and we'll finish with what we can do. Clinical suspicion of the diagnosis of these respiratory illnesses, isolation measures, and treatment when appropriate. Next slide, please. All right, so I'm sure you've seen this all over the news, both in the radio, the television, print media, and Facebook and Twitter. And what people refer to as a tridemic is the confluence of 3 respiratory illnesses: COVID-19, in which we are very much in the midst of a pandemic still, respiratory syncytial virus, or RSV, commonly called really sick virus by our pediatrician colleagues, and influenza A, B, those are the most common ones that we see. And the issue is that people are getting respiratory illnesses in what seems to be a more commonly than in prior respiratory seasons. And we'll talk a little bit about that in the following slides. Next slide, please. So how do we get to be with this? Well, the pandemic made us all hide in a cave. And then when we were able to start coming out of the cave, we were asked to wear masks. And the idea was to prevent the spread of respiratory illnesses by wearing these masks, because they block the droplets in which those viruses are contained, and we get it by taking a whiff of or touching it and then touching our faces. And that had a significant impact, right? So if you look back at the data of cases of influenza during the first year and a half of the pandemic, influenza pretty much disappeared. Like, there were no influenza cases to be seen or talked about. And that was, I think, in large part because of the use of masks and social distancing. But now that the mask mandate era is over and very likely never to be seen again, we have now the resurgence of common respiratory illnesses that were away for such a long time. Next slide. But now life continues, right? We come back to gatherings. The holidays are upon us. Thanksgiving is tomorrow. And, we will get together with the people that we love, because that is life. They did a really interesting study about why people lie about COVID and the precautions that they're taking for COVID. And the bottom line is people want to get back to what they believe was normal in life. And they've suffered enough, and they're ready to just take whatever destiny sends their way. And so whether or not we agree with that fully, that's a completely different thing to talk about. But we are now luckily in a much better place than we were at the beginning of the pandemic. We know how to prevent it. We have vaccination. We have widespread diagnostics, and we have treatment available. The temperatures have also come down. That's why there's this kid wearing a hat there. And the colder it is, the more time you spend indoors. So that makes it easier for people to catch respiratory illnesses and all other sorts of illnesses as well. Kids are right back to getting colds the way they used to. And sadly, some kids, especially with RSV, get really, really sick from these respiratory illnesses. And they require the use of healthcare resources, either in the emergency room or leading to hospitalization. And that's what we're seeing with the convergence of these 3 respiratory illnesses. Next slide, please. So we'll talk a little bit about vaccination. Now, vaccination is one of the most important things that we can do to prevent severe illness from these respiratory viruses that lead to hospitalization. Now, one of the difficult things to remind people is that vaccination may not prevent infection, but it prevents the development of severe illness that requires use of the healthcare system. And so here on the top left, you see a graph showing flu vaccination coverage by age group from ages 6 months to 17 years for the past 10 years, from 12 years, 2010 to 2022. And you see that the younger patients have a higher degree of vaccine coverage than the older patients. And I think it's because, parents, we want to protect our kids. And again, they still get the illness, but they're not sick enough to need health care. And so I think we vaccinate our kids more than we do as people get older, because we just think they're at higher risk. And the second graph here is just comparing the vaccination coverage by state in the same age group. And you see that Nevada is third to last. And so not a good spot to have, but in all honesty, the rest of the country doesn't do significantly better than we do. If you see Massachusetts, which is the best performing state in influenza vaccination, they're still only at 77.7%. So we still have a ways to go, and there's many different reasons why people choose to vaccinate or not vaccinate. And most of the time it's not an issue, but when everybody gets sick at the same time and they all need hospital care at the same time, that's really when we get in a crisis. Next slide, please. Now, briefly, let's touch about COVID. So cases of COVID, 98 million cases. The trend of that is about the same. 1,073,000 recorded deaths in the United States from COVID. That makes us #1 in deaths worldwide. Luckily, there's fewer people dying of COVID, but in my opinion, still in an unacceptably high amount. The hospital use of beds from COVID patients as of last week when I finished these slides was 21,000 people, and only about 11.3% of people in the United States have had one booster dose in addition to a completed schedule of vaccination. And this heat map here shows us the percent of US population that is greater than 5 years of age that have had a complete vaccination series plus one booster dose. And so the darker the blue, the higher the amount of people that have completed this. And if you look at Nevada, we're still within the 30 to 39, so just under 40% of people have had a complete vaccination series plus one booster dose. And we have a way to go, and there's so much that we can talk about whether this is a worthwhile effort or not, but we'll leave that for another talk. This is just to let you know where we're at with that. Next slide, please. Now about RSV, there is no vaccine for RSV that has received approval, but Pfizer is working on a RSV pre-fusion protein investigational vaccine that is showing really, really good results. So the efficacy of the vaccine in the trial is 81.8% against severe medically attended lower respiratory tract illness in infants from birth through the first 90 days, and an efficacy of 69.4% through the first 6 months of life. And they've found that if you vaccinate pregnant women, that their children receive protection from them for the first 6 months of life. Now, why is this transcending? Because the highest period of risk for severe outcomes in RSV disease is within the first 6 months of life. Babies can get so sick that they can either get respiratory failure from pneumonia from RSV, or they could just stop breathing. Like they get apnea, and that's one of the most feared complications of RSV disease. And that happens, the highest level of risk for that to happen is within the first 6 months of life, which is why this, if it makes it to approval, will really be a game changer. Now, we worry the most about RSV illness in children because they can have such severe outcomes, but also in adults. Older adults have a significant disease burden with this disease, and they use a lot of hospital resources as well. So I hope that this comes through and that we're able to use this in the near future. Next slide, please. And now let's talk about the theory of debt immunity or immunity debt. And I like this piece from McGill University, which is a huge university out of Canada. In fact, one of the fathers of internal medicine, Sir William Osler, was a graduate of McGill University before he came to Hopkins. And they have an Office of Science and Society, and I really love their slogan, separating sense from nonsense. That's a Herculean task. It's very difficult to do that. And they put out this piece about immunity debt. Now, some people believe that public health measures against COVID-19, including masking and staying home, have resulted in an understimulation of children's immune system called an immunity debt, and that children are getting more sick now because of it. Now, this phrase comes from a French position paper that was published in 2021, where they cited this as the cause, but they provided no evidence to back up this claim. But overall, it is thought that it's not that children's immune systems are weaker because they haven't been exposed, but rather that they're all being exposed to viruses from which they were shielded when public health measures were in place, and they are now falling ill at the same time. So it's easy for people to say, well, because you haven't gotten sick the way you should have gotten sick over the past 2.5 years, your immune system is now weak, and you get these regular viruses, and now they hit you harder because your immune system is weak. And really, what they're trying to say is, well, it's not really that. It's not that your immune system is defective or that you have a debt of immunity. It's that everybody's now getting sick at the same time. And that's why they see an increase in the use of healthcare resources and hospitalizations. So in the past, because everybody got sick all the time, 365 days a year, not everybody needed the hospital at the same time. But they do now, and that's really what's causing the crisis. Next slide, please. And so this is just to show you that paper, which was Dr. Cohen's paper that was published in 2021. And one of the critiques that they had on that was, look, the whole paper is written in a narrative that is definitive to say that this is the reason why this is happening. And only at the end do they say, well, this may be the reason why this is happening. So they got a lot of criticism for that. And on the right side here, it's from a website called Newswise. And I put this mainly because I like the graphic here, which has a truthfulness gauge, right? And I really like that because this is how we should look at anything that we read that is published, right? It's easy to say that because it was printed or published in a medical journal. Hold on one second. That it is true because it was published, but I like this gauge, right? It goes from false to true, and this is about half true. Next slide, please. So the tridemic emergency, it really is an emergency, and we don't see this much on the adult side of the hospital world because we don't have children's hospitals. Children's hospitals are few and far between across the country, and they usually don't make it to the news, but this has been all over the news. Hospitals for children, especially in Nevada, are inside of adult hospitals, and they're very small footprint. And so it's easy for them to become overwhelmed. And huge pediatric dedicated hospitals are few and far between across the country, and even they have been suffering. So it really is an emergency. There's a lot of pediatricians that have been interviewed, and they're saying this is our COVID, right? In the beginning of the pandemic, everybody was worried about what this would do to children. Children didn't end up in the hospital like we thought they would, thankfully. And so the adult physicians really took the brunt of the work. And now, with the convergence of these 3 respiratory illnesses, the pediatricians are suffering, unfortunately, what we suffered in the adult world with COVID. So it really is an emergency. Next slide, please. And so this is just some local data. People from SNHD, if I messed this up, please forgive me. But I just wanted to show that there is an increase in the amounts of respiratory-like illnesses of people coming into the emergency rooms. And you can see that in the top left square. On the right top, there's the age distribution of ER visits for influenza-like illness. And you can see in the red that the younger population is the one that needs healthcare resources the most. And this is why it's leading to this so-called tridemic emergency. On the bottom left, you see the comparison of influenza numbers in trends in Clark County. And you could see that in the green, it doesn't look so bad now, especially as compared to the previous year. But on the right, on the lower right, you see the map of the United States. So purple is the worst, right? That's where the worst amount of influenza cases are. And you see Nevada still yellow, so it's not so bad. But let me just say that it's not so bad yet. And so these illnesses, this wave of respiratory infections usually moves west from the east, and it is yet to be seen where we end up with that. So any effort that we can make towards decreasing the risk of us being overwhelmed is something that we need to do. Next slide, please. And this was such an issue at a national level that the CDC has come out with an official health advisory about increased respiratory virus activity, especially among children, early in the fall and winter of 2022 to 2023. So this is CDC saying, look, there's places that are in the brink of collapse. There's places that have had a 300% capacity in caring for these children. Do whatever you need to do to get ready should that happen to you. And so this is a fair warning shot from CDC telling us this is a huge thing. Get on it so that you're prepared when it comes to you. Next slide, please. And this is just a little bit of data about RSV. And so just like we looked at some of that COVID and influenza data, this green line here, that's sharp increase in RSV infections, you could see it's overwhelmingly worse than previous years. And this is why we're in such a difficult situation. And you hear very little of this in the clinical side. I'm sure the epidemiologists are all up on this all the time. But this is just a quick representation for those of us that don't do epi every day to see how bad it really is. And a graphic representation is usually helpful with that. Next slide, please. So what else can we do to help? And that's what I hope this message comes through. Next slide. What we could do is vaccinate. We know enough about the safety and efficacy of COVID vaccines. We know that it's the right thing to do. We should do it. Everybody from age 6 months and above can get a COVID vaccine, and they should, unless there's any contraindications, which are extremely few. The same is true for influenza, because it is another tool for you to prevent the convergence of these respiratory illnesses and ultimately prevent severe disease, which is the main purpose of vaccination, right? We're not looking to block. It's not a zero-sum game. We're not looking for people to not get any infection. We just want them to not end up in the hospital. So that's the first thing. The second thing here, illustrated with this cartoon in the center, is the clinical suspicion, right? So when somebody comes in with a respiratory illness, you look at that syndrome, that set of signs and symptoms, you have to think about COVID, you have to think about flu, and you have to think about RSV. Now, testing for COVID is important. Testing for flu is important because there's therapies associated with it, right? You pretty much need a COVID test or a high suspicion of COVID to prescribe Paxlovid, although you don't need a positive test to actually prescribe it. Like if somebody comes in with a classic syndrome and everybody else is tested positive around them, it's going to be COVID. You know, don't wait 24 to 48 hours to get a result. Just give them the treatment and help them to get better sooner. For influenza, you don't need a positive test to treat them for influenza. You have an influenza-like illness, and if COVID is negative and there's no other explanation, you can go ahead and prescribe them some antivirals for that. Testing is important because of that. And it helps the public health efforts in controlling the pandemic. And lastly, to stay home when sick, right? It's easy to not want to burden your colleagues at work and show up to work because you don't want people to have to pick up your slack. And it's not your slack. I mean, you didn't choose to be sick, right? But it's the perception is often that. And the same thing with kids in school. Oh, my kid's been having a cough. He had a little bit of a fever. Let's give him some Tylenol and send him to school. Because I can't afford healthcare because there's nobody else to take care of them. And it's very difficult, but whenever possible, whenever humanly possible, let's stay home when we're sick. Next slide, please. And finally, treatment. So if you have influenza or suspect influenza, there's Tamiflu. You can give Tamiflu to pretty much everybody. And then in the case of COVID, you have two options. The most popular and probably the most effective is Paxlovid. And the other one is Molnupiravir, which is the Merck product. Probably a little bit less popular, but in some patients in whom Paxlovid is contraindicated, molnupiravir, in my opinion, is still much better than no treatment. I wish there was more access to intravenous remdesivir in the context of monoclonal antibodies losing their effectiveness as time goes by, but that's just what we got to do. Next slide, please. And finally, for those patients that are at high risk of severe RSV disease, there is a monoclonal antibody called palivizumab that can be given to high-risk patients. It's sadly not available for the general public, and it is, of course, very expensive. So I hope that this vaccine for RSV does come through so that we don't have to resort to this. Next slide, please. And this is just a recap. We talked about, what in the world is a tridemic? How did it happen? The role of masking, distancing, insufficient vaccination. We talked about the theory of immunity debt and how it is only half true. A little bit about the data of around the US and the state of Nevada. And finally, what we can do to make things better. And so with that, the next slide should just be a thank you slide and an invitation for questions.
We have one in the chat. Should those who have syncytial virus before be administered Prevnar 23 for pneumococcal vaccination, even if they are aged below age 50?
And so there's new guidelines for pneumococcal vaccine that just recently came out, but there's no, that I can recall, there's no issues with having RSV and the timing of pneumococcal vaccination. I don't know if that answers the question.
Dr. Palmer, do you want to unmute and share your thoughts?
Sure. So I was just thinking, we have the husband of the physician who tested positive at home with just nasal congestion, but tested positive for COVID. So it sounds like that healthy person, so he should be on Paxlovid, and again, the same as her because of being a nurse in the healthcare profession, the mask, the 5 days at least, and testing negative.
And I think they should be offered treatment, and talk about the benefits and risks of it. In my opinion, it's very little risk. It's a very well-tolerated drug. And to me, like when I get COVID, you can bet I'm getting myself treated, because 20% decrease in long COVID, I'll take that to the bank.
So I just have one additional question and follow up to that. I had a patient who came in to see me, but 3 weeks ago had COVID, went to an urgent care, was put on Paxlovid. So she and her husband tested positive for COVID. She has AFib, the husband has some medical complications. Why he was told that he had a comprehensive metabolic profile done to check his kidney function because he was being put on Paxlovid, but he doesn't have any kidney problems, but the wife wasn't tested. Do we do that with Paxlovid?
No, so if you have a history of renal disease,
No, he didn't.
you need to know, because there's a dose adjustment for Paxlovid, right? So if your GFR is below a certain amount, you give only one of the 2 pills, and so you need to know. But if you don't have a pre-existing history of renal disease, you just treat.
I was just wondering, they're both in their 70s and they tested the husband but not the wife. So I was just sitting here thinking about that when you were talking.
Like the AFib, what I would tell people is, what are they on for AFib? Is there an anticoagulant that is in the picture, or an antiarrhythmic?
Yeah, she had to stop both.
And I tell them, my favorite resource for this is Liverpool University in the UK has a calculator for medication interactions for all COVID therapies. So you hop on there, you say, this is a patient with COVID that I want to give this drug to, and then you put in the other medicines that they're on. It rapidly identifies the interactions and it grades the severity of the interactions, so you can make a decision with your patient. It also gives you some hints about how long should you stop these other drugs before you can start the Paxlovid, or how long you should hold these drugs after the Paxlovid is finished.